I'm Pat Saffy. I'm sure most of you know me. And Dr. Tammy Bailey Stanton has asked me to talk on organophosphate poisoning, which is more correctly called acetylcholinesterase inhibitor poisoning, because that encompasses the two major products that we see. One is being organophosphates and the other one is carbamates. So what we're going to do is we're going to look a bit about the history, because I think that is actually incredibly interesting and quite horrifying, actually. And then signs and symptoms, differential diagnosis, the cholinesterases, decontamination issues, treatment regimes, anticholinesterase issues, things that are debatable in the literature, possible new treatments and why, long-term sequelae, and the issue of notification. If anyone wants to ask a question, they better just butt in. Otherwise, at the end, I'm happy to take questions. Okay, so organophosphates was still first described in the 1850s, which is a long time ago. But it then got really researched in the 1930s. A lot of it started in Germany at the time of the build-up of before the Second World War. And at the same time, there were these strange things in America. Some of you might know the prohibition, and people weren't allowed to have alcohol. So people were trying to make alcohol out of strange things. So in Germany, we got a whole lot of things developed, which you might have heard of these. Tauben, sarin, soman, and cyclosarin. And these were developed for various reasons, mainly officially as pesticides for crops. But a lot of it was also considered in warfare. And at the same time, with the prohibition in the United States, people were starting to make alcoholic beverages out of these medications. And so people were starting to drink these organophosphates. They didn't realize it. And as a result, in that time, there was a lot of muscular damage done to people because of organophosphates, which comes back to the long-term sequelae of organophosphates, which we'll talk about later. Then it didn't develop much more, but in the 1950s, another organophosphate was developed, which is called the VX organophosphate. And then in the 1990s, people are still developing these things, and they're ultra poisonous, and Novichok was developed. You'll see this in history now. And so if we look at history, we have these really sad issues where, as much as it was used as pesticides for cockroaches and whatever, people are using it to kill people. And one of the attacks was the Tokyo subway attack in 1995, where sarin was used. And this was basically by some random psychotic person who had an issue in Japan, and he sprayed the sarin in the subways. And a lot of people were killed at that time, and a lot of people had a lot of damage from this. This fear always comes to me because if anyone's been to the Santon Gautrain, we know we go deep, deep down to get onto the Gautrain, and this is the sort of thing that happened in Tokyo. And it could be a real disaster because these are gas sprays. Similarly, in Damascus now in 2013, which is like just on 10 years ago, as you know, the Middle East is a problem, and they took aircraft. I don't know if it was helicopters or airplanes, but they sprayed sarin as well over suburbs of Damascus. and many people were killed and damaged in that attack on that day. I don't think anyone actually knows how many people died. Anything between 300 and 1,300 people were killed in Damascus because of sarin. So these are real things that are happening in our century from organophosphates. And therefore, it is a worldwide fear. But we'll get back to that. Another interesting historical evidence of organophosphate is the assassination of Kim Jong-nam, who was a half-brother to Kim Jong-un. If anyone knows, Kim Jong-un is in charge of North Korea. And this happened in Malaysia. And this guy was walking in the airport in Kuala Lumpur, and two officially young girls came running past him, and they touched his face and his neck with gloved hands, just running past him. And he was going to fly out. And then within minutes, he didn't feel well. He went to the medical area of the airport, and before the ambulance could get there, this guy was dead. Basically, he was assassinated, organized by his half-brother from North Korea. That is how potent that little bit of VX is through the skin. Then another tragedy, probably some of you know about, Navalny, who was suddenly died earlier this year. But this is a Russian anti-Putin person and his daughter who were poisoned with Novichok, and that was in earlier in a few years ago, 2020. He was managed to get out, and he was taken to UK where he got treatment and survived. When he was able to walk again, he went back to Russia where he was arrested. He was put in prison, and he suddenly died this year because Putin didn't like him at all. It's another tragedy. Just to note, the red arrows show the tracheostomy marks of the long-term ventilation that he required, and his daughter. Here is a very important pathophysiology of these agents, acetylcholinesterase inhibitors. Joke at the top, you can see the guy is spraying the pesticide, and the bugs are saying you're going to die on your own poison. What happens if you look at the bottom? The poison, we'll talk about it. It can be inhaled, go through the skin, go through the gut. It gets into the system, and it destroys the acetylcholinesterase inhibitors that are sitting around the sites of the muscarinic and the nicotinic receptors. The acetylcholinesterases are supposed to break down the acetylcholinesterase, the acetylcholine that is jumping between the neuromuscular junctions, and recycle them. And the poison blocks that enzyme, and therefore there is overstimulation of the neuromuscular junctions there, if you can see that. And that is what gives us a lot of the clues of the effects and what we see with the signs and symptoms of this overdose. So what do we see? If the acetylcholinesterases get into the system, and we'll talk just now about how they get into the system again, we have the acute effects, and we need to recognize these effects. The first one is the muscarinic effects. The muscarinic receptors are all over the body, and everyone must know dumbbells, because that explains exactly the muscarinic effects, and I think it's quite the easiest way to remember it. because they are almost all secretory. So everything that can secrete and excrete is muscarinic. And so that follows with the diarrhea, the urination, the bronchorrhea, bronchospasm, the vomiting or emesis, the lacrimation, and the sweating and the salivation. It also causes meiosis, bradycardia, which are not excretory effects, but they are very prominent and important muscarinic effects, which are sometimes our biggest clues to what's wrong with the patient. So we really have to recognize these effects and know them to be able to recognize the disease process and treat it. We always talk about the killer bees. The killer bees I've highlighted are the bradycardia, the bronchorrhea, and the bronchospasm, because those are the things that are going to kill you. Salivation is not going to kill you. Meiosis is not going to kill you unless you can't see and you crash into something. But the acute onset of the bronchorrhea, which floods your lungs, means that you get severe hypoxia. You cannot breathe, and we all know if we have hypoxia, we cannot breathe, we will die. And it can happen extremely quickly. The other one is the bradycardia. If you go down to a severe bradycardia quickly, you have no output, you develop a pulseless electrical activity, and obviously you die. And that is what we see mostly in the acute phase of these patients. And they really rapidly die in front of us because of the killer bees, the bradycardia, bronchorrhea, and bronchospasm. The other one are the nicotinic effects. So it hits the muscarinic receptors all over the body. It hits the nicotinic receptors all over the body. And the mnemonic isn't so important here. It's Monday, Tuesday, Wednesday, Thursday, Friday, if you want to remember it. But the most important thing to understand is that you get weak. Woe is Wednesday and you are weak. And if you are weak, as you can see from the picture here, the most problematic part of weakness, as we know from many disease processes, is if your lungs can't breathe, your diaphragm and intercostal muscles cannot breathe, you cannot pull in air, and believe you me, you die because you can't breathe. And we see this, we see these people, and we forget about it. We're so overcome with the muscarinic effects, which are so dramatic, that we miss the subtle weakness that happens in these patients. And they often get put in the ward. They think that we've controlled the muscarinic effects. We can't control we don't watch the nicotinic effects, and the patient slowly, simply stops breathing. We need to be monitoring that. We can monitor it very easily clinically by asking the patient to grasp your hand or to lift their head. If you cannot grasp the hand properly, you have no strength. And that is going to be an indication you probably can't lift your head up. If you can't lift your head up, it's telling you your muscles are weak. And if you can monitor, say, the PCO2 on a blood gas, you will find the patient PCO2 is getting higher and higher because they can't breathe. And you have to breathe for them, which means we have to intubate and ventilate them. Please, clinically, you can do this, guys. It is not difficult to ask a patient to grab your hand and see if he's got a firm grasp or not. Lift the head. Can the neck muscles lift that head for 10 seconds or not? So we have to know that. The last one we have to obviously be aware of, which I'm sure we've seen, is the CNS effects, which is a mixture of the nicotinic and muscarinic receptors in the brain. And some people like to use the mnemonic crazy, being the C for confusion, coma, becoming restless, anxious, and they can have seizures. And if you've seen enough organophosphates, you would have seen all of that. So those are the sort of signs and symptoms that we look out for. Please remember, guys, you're not going to see all of them on one patient at once. It is not possible to have mydriasis and meiosis at the same time. It is not possible to have a tachycardia and a bradycardia at the same time. So you're going to have to look out for the different effects and marry them together. One patient might be full out CNS coma with some sweating and diarrhea. Another patient might just come in with a severe weakness and mydriasis, the classic nicotinic effects. The majority of our patients that I've seen, mainly the first effects are muscarinic, which is what we pick up in the EDs and start treating. So those are the signs and symptoms that we have to look out for. As I've said there, we're looking at it clinically. It is usually a clinical diagnosis. There's no test I can do immediately to make the decision. Just to be very aware, a lot of people will tell you that they took rat poison. We need to know that there are two types of rat poison. The Coumadin or warfarin rat poison, which is those big sort of bluish green granules, which you've probably seen, and then the acetylcholinesterase type of rat poison, which is these tiny black granules, which also looks like poppy seeds and can be highly mixed up with people. They think, oh, it's a poppy seed on the bread or whatever, and then they eat that. So if anyone tells you if they've taken rat poison, you need to get in the history. Which rat poison did you take? Because the treatment for the two is completely different. Okay, questions. Why do we see this? Well, in our country, the biggest one is suicides and parasuicides. I'm sure most of us have literally heard the patient comes in, or the relatives come in, or the friends come in and say they took step 1 or step 2 or haliparimi or whatever to commit suicide or attempt suicide. Unfortunately, we also know that people try and kill people and do successfully kill people, and so it is a homicidal poisoning as well. We've already talked about the genocides, huge populations being killed by it. It is very easy for that to happen as well. And then in our country and in many of, especially third world countries, we do have the accidental poisoning in agricultural areas and in pediatrics. And I think even in this last week, there were kids where they claimed they were accidentally poisoned at school. I think 40 of them, and this was probably it. Sprinkling that little black things into granules, everybody ate it, and they came in with these muscarinic effects. And we see that regularly in our country. So whenever you see these people, you need to be checking for this and working out which one is likely. Remember, if it's homicide, you have to tell the police and investigate very carefully. Obviously, if it's genocide, well, it'll be a complete disaster for all of us. When we're looking at this, we have to also be thinking around, because it's not always clear that it's organophosphate poisoning. And sometimes you've got to think of a differential diagnosis. Here we have an 80-year-old male comes in, he's unconscious, he's sweating, he's got pinpoint pupils, he's got wet underpants. Is it a head injury? And that could be a pontine stroke or something. They have pinpoint pupils, so a bleed. Is it a seizure, wetting your pants, having had a seizure? In people, there are many other causes of pinpoint pupils. We obviously know opiates very commonly, but then there's all the other ones like clonidine, GHB, angel dust, risperidone, phenothiazines, amitraz. All of those other things can cause pinpoint pupils. Shock state can cause sweating, wetting your pants, dropping your blood pressure. You might muddle that up. And obviously mushrooms that cause the muscarinic effects are going to look just like organophosphate poisoning. So there's always a differential. Clearly, it's very easy if the history, they tell you they took haliparimi or step 2, then you know. But if we don't have a history, there's a differential which we have to work with. Another point I want to talk about, I said, it's a clinical diagnosis. We always hear about the cholinesterases. Cholinesterases are the ones inside the cells, which we can call red cell cholinesterase or erythrocyte cholinesterase or acetylcholinesterases. They are inside the red cells. And then we have the pseudocholinesterases or butyrylcholinesterases or plasma cholinesterases. They are in the plasma of the blood. Why do we have to know this? Well, there are a few reasons. I'll talk about one just now, but you must remember pseudocholinesterases are reasonably easily measured in many laboratories. And if a person is poisoned, these levels will drop considerably because they're now damaged by the poison. The red cell cholinesterases are also damaged by the poison, but we cannot measure them easily. So if you ever send off a red cell cholinesterase, the chances are you'll never get the result back because it will go to somebody who doesn't know what to do with it, and it'll sit around, or it might, if you're lucky, get to Charlotte, and from Charlotte it might go to some private lab, and you will never get the result back. So although the literature says red cell cholinesterase is more accurate, it is pretty much impossible to get hold of. So pseudocholinesterases we can measure reasonably quickly and get a result. But it's not that quick. You can't make the diagnosis on it because in most places it's going to take 8 to 12 hours to get the result.
Hi,
I
Pat.
do suggest.
Hi, it's Tammy.
Hi.
Just so that everybody also knows, we used to be able to get red cell cholinesterase in state. They always used to be run at the Gen, so Charlotte Makeke Hospital. But now, in the last few years, they've stopped allowing red cell cholinesterase to be measured entirely. They won't even send them to private laboratories. They've taken that facility away from us. And this I've discovered in ICU, because it is one of the places that you very well might have done a red cell cholinesterase because they're there for so long, you'll get the result. Yeah, it's
Yeah.
very frustrating, actually.
Yeah. So it's just a waste of time, waste of money, costing. So use the pseudocholinesterase, and especially, I think Tammy works in ICU, but in the ED, if you suspect homicide, take it. It is proof if anyone ever has to go to court. If the patient goes long-term to ICU, obviously you're monitoring the regrowth of the pseudocholinesterase to see how the patient's recovering and if the acetylcholinesterase inhibitor is decreasing in the blood. But in the ED, that gives us a clue. Initially, it doesn't help us, but for homicides, it is proof then that this is the cause. It wasn't a shock state. It wasn't a pontine bleed. It wasn't something else. This helps us. So it's a long-term thing. It is not a short-term thing. Thanks, Tammy. What we also have to understand, which I touched on earlier, is the various ways that these poisons get into the body. You've seen how Kim Jong-un's half-brother was killed. It was simply touched onto his skin, a small amount. It was absorbed through the skin. So if it's eyes or skin, it can be absorbed through the skin. It can be breathed into your lungs. And in our case in South Africa, most of the time we are seeing it by oral ingestion. So any of those things can cause the poisoning. With oral ingestion, we are reasonably safe. We are not going to touch it because it's not all over the skin of the people. So the normal PPE or gloves is adequate for you. You're not going to die from touching the patient who's swallowed the poison. However, in these places like the Tokyo and the Damascus tragedies, if you go in to rescue those people, imagine going down Sandton train station. If you go down in there without protecting yourself, of course you're going to inhale the poison. Of course you're going to die next to the patient next to you from organophosphate poisoning. So here you can see people are fully covered, their mouths, their heads, their hands, everything is fully covered before they can go into these areas where they have to rescue people. And here you also see the big water sprays. If we ever, please God, we don't, but if we ever have someone come in and spray a whole lot of the stuff over maybe a soccer stadium or something like this, like what they did in Damascus. No patient can come into your ED without being hosed down, everything removed from that patient, and everyone would have to be fully covered to touch those patients. Otherwise, it will absorb into your skin and you will be poisoned. In some of the countries where I've worked, they have these showers in the ambulance area. So patients will come out, they can switch on the showers, people have to be washed under the showers. The water is then caught into bins underneath the ambulance area because it's contaminated. It must not go back into the rivers and the sea. And countries that are very worried about massive chemical warfare have these sorts of things outside their EDs. We don't seem to have those sort of thoughts. We have our own ways of killing each other. So decontamination must be considered depending on the history of the patient. The treatment regimes, hopefully most of you are familiar with this. In the old days, they used to give a little bit of atropine slowly. We now know that with our acute poisonings, that is not adequate. And so our treatment regimes are to give a lot faster. And the first thing we do is consider the killer bees, stop the bronchorrhea and the muscarinic effects. And the anti-muscarinic drug we use, I'm sure you all know, is atropine. And that is a muscarinic drug. It is not nicotinic. It will not sort out the weakness, but it will stop the secretions. And so for most patients, we immediately start with atropine. And the dose of atropine, guys, you have to understand, is a maximum dose. If you used atropine for anyone else, you would start with a minimum dose, which is considered 0.02 milligrams per kilogram. But if you think if you're all sitting here, all your nicotinic and muscarinic receptors are free. If you're being poisoned, all of those receptors are blocked. You need to give a large dose of atropine to try and compete in that blocked area. And therefore, we start at what would be a normal maximum dose of atropine, which is 0.04 to 0.05 milligrams per kilogram. If you've got an acute organophosphate, and I'm sure many of you have seen one where they're vomiting, they've pooed, they are wet, they've peed, the bronchorrhea is frothing out the mouth, you have to hit them with atropine. So you start with the maximum dose, 0.04 milligrams per kilogram, roughly. Similarly with children, and you go up from there. So you give the first dose, you assess them after 5 minutes. Are the secretions drying or not? Specifically the bronchorrhea, because that's what's killing them from the hypoxia. If not, you double the dose. You wait 5 minutes and you see if they have improved. If not, you double the dose. And we get to extremely high doses before we feel controlled. But guys, don't overdo it. You've got to balance. Does the patient look like he's getting better? And then you can slow the treatment regime down. Or is he not getting better? And sometimes I think, and the studies have shown, that we are overdosing our patients. I'll talk about the anticholinergic syndrome. We need to control them so that the hypoxia is improving, the gas is improving. We can see it on the gas, we can see it on the patient. And then we stop the loading dose, which is double dosing every 5 minutes. Please remember that that is a muscarinic treatment only. Atropine treats the muscarinic effects. Then we also have what we call 2-PAM, which is pralidoxime, or in our country we have obidoxime. We don't have 2-PAM or pralidoxime. They are the oximes that are considered the actual antidote to the entire acetylcholinesterase inhibitor, but it's a Section 21 drug. It is not freely available to us, and so we don't use it. It is also expensive, and even in the literature, there is a lot of studies to say, well, I'm not sure if it actually works any more than the standard atropine and supportive management. So mainly in our country, when we're seeing this sometimes daily in some of the hospitals, we are not using oximes. And certainly if we're not seeing daily, we haven't got Section 21 forms and we don't use it. That is the other, the main antidote that's described. Then do not forget your benzodiazepines. They are very useful. Obviously, they stop toxic seizures where we can get this. They calm patients down. If you're ventilating them, you can use them to calm them down. And it is strongly postulated in the literature that your benzodiazepines relax the muscles from the twitching caused by the acetylcholinesterase inhibitors, and that reduces the potential for the muscular and neurological effects that patients see in the long term. So please feel really free to use your benzodiazepines in these patients. Obviously, you don't whack a patient whose GCS is 15 out of 15 with 15 milligrams of midazolam when he's not showing those effects. You use it judiciously, but if you've got an intubated patient, this should be your first-line sedative because it has other benefits for the patient. So those are the 3 treatments we need to be aware of as standard of care for organophosphates. Treat the muscarinic effects. We can't use an oxime. Consider the benzodiazepines. Just to talk about the anticholinergic toxidrome, because that is the overdose of atropine. I'm sure you've all heard about hot as a hair, dry as a bone, blind as a bat, red as a beet, mad as a hatter. And we see this in our patients because we have overdosed them with atropine, and then we have to bring down the atropine. And the patient is burning up, their pupils are dilated. If they're not intubated and sedated, they're running around the ward like mad hatters. And we've given too much atropine. That is why we need to watch the amount of atropine we do actually give them and slow it down if it's too much. I need to add there, if you've given the atropine to stop the hypoxia, then the plan is after that is to run an infusion of atropine at 10 to 20% of the dose the total dose. So you add up all the atropine you gave. If you gave 100 milligrams, you will say, well, then this patient needs 10 to 20 milligrams an hour. And it becomes a clinical situation. If the patient becomes cholinergic again, you've got to increase the atropine. If they become anticholinergic, well, you've got to decrease the atropine and increase the benzodiazepine to calm the poor patient down. Then people talk about test dose atropine. Now, really, this is beyond my comprehension because it's only a test dose if you're not sure if the patient is really an organophosphate poisoning. And so it's a small dose to see if they respond like we would expect someone to respond to the atropine if you suspect it. But this is not a classic OPP patient that you are dealing with. This is a query patient. So it is rare that we have to worry about test dose atropine, but a lot of people seem to bring it up. And a clear-cut OPP, you give the correct dose initially and go up, which is the 0.04 milligrams per kilo immediately and go up from there. Don't play around with mini mouse doses of atropine when you've got all these secretions going on. And then if you do give a test dose, if the patient is not an organophosphate poisoning, usually if you give the atropine, you're going to see a whacking tachycardia, and you can be sure that they are not at the stage poisoned and their receptors have not been blocked. I hope everyone understands that. Then I want to just talk something about oxygen and atropine. Sorry, I'm not sure if you're aware. So, because this is, I don't know if you heard that, it sounded very faint to me, but we always taught that atropine must never be given in a hypoxic patient because it will kill them, because it makes the heart rate go faster, the oxygen is chewed up, and the heart arrests. But this is the one time where we have to give oxygen and atropine together. We have to oxygenate that patient, and we have to dry the secretions. So organophosphate poisoning always causes complications to general things we've learned. So the atropine solute, as I said, exclude or watch out for hypoxia. Do not give it in head injuries. Do not give it in hypothermia. But in organophosphates, you give atropine even though they're hypoxic, but you treat the hypoxia. That is absolutely essential, because most of our patients are likely to be hypoxic, and it can be given IMI if necessary if you can't get a drip up initially. And you must treat the oxygen at the same time as the muscarinic effects. Adrenaline can be always used as a vasopressor, but it is not a first-line treatment for organophosphate poisoning. Treat the patient symptomatically, give them atropine, and see how they respond. If they are not responding and their blood pressure is still on the ground, then you can add the various vasopressors, of which most of us have adrenaline all the time. There are a lot of cardiac toxic effects of organophosphates. I think it's come up at least twice in our FChem Part 2 exams, the cardiac toxic effects of organophosphates. And so if you're seeing this, you're probably considering cardiac effects. Just for example, this is a classic ECG of a tachyarrhythmia with atrial fibrillation directly resulting from the patient that is hypoxic from organophosphate poisoning. There are many, many effects on the heart of the organophosphates. Now, if we want to just look at it, we've talked a lot about the atropine. We must remember the weakness. If the patient is getting weak, the only way we can treat us is to support the patient, which means we must intubate and ventilate this patient. And then the question clinically becomes, well, what do I do? And the question then is it everything or nothing? And a patient who's in cardiac arrest, you can put a laryngoscope down their throat and put a tube in as fast as possible and bag the patient to get oxygen into their lungs. You do not have to paralyze a patient in cardiac arrest to do that. And that is what we sometimes have to do, and you don't use drugs. Then you have the patient who's in front of you clenching his mouth. His GCS is 14 out of 15. But he's pouring secretions out his mouth. Obviously, you are going to have to do a full-on drug-induced rapid intubation sequence, and you're going to have to use a hypnotic and a muscle relaxant. So we've said, ketamine is fine, etomidate is fine. Benzos probably are still too slow acting to use them in the acute stages. And I wouldn't use propofol because it's a hypotensive agent. And with the chance of cardiac toxicity, you do not want to use propofol for our toxic ingestions. And then after the sedative, we have to choose the muscle relaxant. And here, rock is king. Why is rock king? Because sucks is not a good idea if you have organophosphate poisoning. Okay? It is broken down by the plasmacholinesterases. And as we discussed before, plasmacholinesterases are damaged by the organophosphates, so sucks won't break down, which means the sucks will keep the patient paralyzed for hours. So it's considered a relative contraindication because if you can ventilate the patient, that's okay. But if you use sucks, please tell everyone you used it. Because, I mean, just recently we had a case where the patient was there and the patient's not twitching, they're not moving, they absolutely look like they're completely dead, but they've still got pinpoint pupils. And suddenly 6 hours later, they start to twitch and move because they've been paralyzed, they're not dead. And we do not want to say, oh, he's dead and switch off the ventilator when actually he's just been paralyzed from the succinylcholine. So you might be in a situation where you have sucks and you have no rock and you have to use it, but then you must pass on the information so that we keep ventilating these patients, and usually between 6 and 12 hours later, they actually start to move and you say, he's not dead, he's just had sucks. And so it's very important that you remember that sucks is a problem in organophosphate poisoning. Just for fun, I found this at my local shop some time ago, where it talks about there you buy your Vaponabincil. It's clearly an organophosphate, dichlorphos. It's supposed to kill the flies and whatever's in the bin. And if you see where I've highlighted there, your antidote is atropine, which is not really your antidote, because your antidote is atropine. But I think, I just thought this was really funny. This is a commercial product and they're telling us the wrong dose or the wrong thing. But there you see there until there's atropinization, and then you use 2-PAM or other oximes. And here they say it's contraindicated in dichlorphos, so they don't use it. Anyway, so atropine and atropine are interesting issues. So we go with that. We go with the atropine. We go with intubation if there's weakness, which we can see clinically, or they're extremely hypoxic, and you need to support them. And then you give supportive care to the patient. People are worried because this is chemical warfare, which I talked about earlier. And so forth, there's a lot of investigation in the Northern Hemisphere. What else can we use? And there's not a lot of evidence what else can be used. And here is just a list of things people have used and tried to use. Magnesium has been shown to be very useful. I think it's a muscle relaxant, but the doses where it was useful were actually extremely high. They were talking about 4 grams every 6 hours. So that is 16 grams 24 hourly. So a small dose of magnesium is really neither here nor there on the patient. You need to give a lot of magnesium to help these patients. Salbutamol for the wheezing can sometimes help with the ipratropium because it's also an anticholinergic and dry secretions. But that's not going to help if you got to tube this patient because their SATs are so low. FFP has said, well, maybe if there's pseudocholinesterases, it can gobble up the organophosphates. People have tried that, sort of diluted out. Lipid emulsions have been used. They've been fine. If it's a lipid-soluble organophosphate, we have hundreds of organophosphates. So to know which one is a problem. And most of the time, as you've seen from the packaging that I showed you earlier, you don't know which organophosphate this person has had, or if it's a carbamate, we have no idea. So lipid emulsion in our case probably would be just a thumb suck to try. Glycopyrrolate has been used in ICUs because atropine crosses the blood-brain barrier and glycopyrrolate doesn't. So it's not for acute ED use, but certainly if the patient is going cuckoo in ICU, we've replaced it with glycopyrrolate, which helps a lot, but it is more expensive. And then there are a whole lot of other issues that people are trying to get reactivators to get the enzyme to work again so that the acetylcholine can be taken up in the receptor sites. Long-term consequences is always a problem. We treat them initially in the ED. We often don't see the long-term consequences. There's an intermediate syndrome where you think they're getting better and then they get worse again. This is a crisis because if you take them out of a high care area, you're not watching them, they die in the middle of the night, which is what we've seen. There has been described the increased incidence of cardiovascular disease afterwards due to the poison to the heart. The neurological effects we talked about in the 1930s in the USA, by drinking all these things that they wanted to get hold of for the alcohol, they got the organophosphate-induced polyneuropathies, and they couldn't walk and they had to hop along, and there was a lot of damage done there. And people who have organophosphates can have long-term poly or mononeuropathies when they leave the unit, which might never recover. And then we must always remember, I mean, if you've been in such a terrible thing as a sarin attack, you're clearly going to have a post-traumatic stress disorder. This cannot be a fun thing if you even survive. So they and if they have cardiac arrest on us, guys, we have seen them as vegetables or brain damage, and that is really sad as well. And I'm sure a lot of us who've seen this have seen this happen. My last slide, I think, for today is to remind us that this is actually one of the few notifiable conditions that is not an infective condition. It is a type category 2 notifiable condition. And the idea is that you're supposed to notify the authorities so they can go and find out where this has happened, stop the stuff getting into the schools, make sure that agriculture is looking after their people who spray organophosphates, and it should not be sold on the streets where everyone can get it and then commit suicide or homicide. But unfortunately, I think most of us never notify this condition and no one really cares, which is really sad because it's a massive problem in our country. So that is a brief summary on organophosphate poisonings. Any comments or questions?
So I wanted to comment, it's Tammy. For anybody who's interested, this topic is quite near and dear to Dr. Saffy's heart. She did her master, her MSc on this topic. So she did her master's, her master's research topic on this exact topic, looking at the incidence of OPP poisonings presenting to the Barra MEU. And you can find that if you go onto the Wits Wired space. One of the interesting things that is being looked at the moment, at least, so I'm kind of talking from the ICU perspective now, hemoperfusion. So it is a modality that is being investigated. And I don't know if you remember Prof. Omar from ICU. He is currently publishing on this topic because he's started looking at hemoperfusion for reducing the duration of stay in ICU, reducing the total dose of atropine required, and obviously reducing morbidity and mortality is the long-term goal. He recently published with a whole bunch of other ICU authors a small case series. I think they did 33 patients, 35 patients, looking at hemoperfusion as a ICU modality that is currently being researched for organos.
Thanks. I think Claire has a question. Claire's hand is up.
Hi, Dr. Saffy. Thank you very much for this presentation. I really appreciate it because I'm working in a little district hospital, and at least on a week, sometimes a daily basis, we see one, if not two, OPP poisonings. But I have two questions because at the district level, we see them, we stabilize them, and then we refer them to Borough MEU. And so there are just two questions from my point that would be helpful for me to know if you could elaborate further. Firstly, you spoke about the pseudocholinesterase measurement. How soon do you need to take blood for pseudocholinesterase? Because for us in the district hospital setting, you see the patient, you get the history, you suspect this is, or sometimes it's confirmed this is an OPP, you start atroponizing them. Then you wait for EMS to come and fetch them and take them to MEU. Sometimes it can be, 2 to 3 hours. Sometimes, like yesterday, we had a 12-hour delayed EMS coming and fetching our patients. So how soon should I draw that blood if I suspect it's a homicide? And, firstly, that's the question, is how soon do I need to draw it? And do I take that blood before I start atroponizing the patient, or does it matter at what point I draw it? Firstly. Secondly, can you speak to what happens when you think you've received atroponization? So you've started them on the atropine infusion, but then you go back to reassess the patient, you realize they still have all of the bronchorrhea and the secretions. Do you start your atropine back at that dose of 0.04 milligrams per kilogram, or do you start at the last dose of atropine that you gave? So let's say you're doubling every 5 minutes, and let's say your last dose that you gave was 64 milligrams, for argument's sake. Do I go back to 2, or do I, double that 64 and give them 128 milligrams? Thank you.
Thanks, Claire. The pseudocholinesterase, it is not the most important thing to do. It is going to crash as soon as, obviously, the receptors are blocked and damaged by the organophosphate. So it's going to crash pretty quickly. So if you've got a full-on classic organophosphate, that pseudocholinesterase is going to be low. But it is not an emergency. It's something you can think of an hour later, 2 hours later. Remember also that pseudocholinesterase is supposed to be put on ice. So if you're pulling it at a small peripheral hospital, it's not going to be done at your hospital. It's going to have to go on ice to go to a more central hospital to be investigated. It is really, if you're moving these patients out, the doctor at the other side can pull a pseudocholinesterase. It is certainly not the most important thing to do at the time, especially if you're not going to follow up the patient. You're not going to get the result anyway. If you are going to do it, then you must make sure it goes on ice to a hospital that has the facility to pull, to read the result. So you'd have to wrap it in ice and send it along with the patient to MEU because they can do it. I would really, in your case, probably say it's not for me to do. Make a documented note. Please take the pseudocholinesterase at that point when they get to MEU, because they can do it obviously at Barra, and you certainly can't do it at a small district hospital. I would just make a documented note to pull it at a hospital where the facility is likely to get it there on ice quickly enough to be accurate. The measuring in the long term, I'm sure Tammy will know you, to see if the patient's improving, then they might pull one every 2 to 3 days. If it's a classic organophosphate, some of the carbamates will recover quite quickly and might start recovering within 8 hours to 12 hours. And they're reversible, so you might not pick it up that quickly. But I don't think it's very useful to do at a peripheral hospital where it's not going to get on ice and it's not going to get correctly measured anywhere. I hope that answers.
I work at a regional hospital, so that's Rahima, and we don't have access to this test. It's only done at tertiary facilities.
Yeah. So I think you're probably mostly wasting time. And if the patient has to go, use the tertiary facility, pull it. As for the dose,
diagnosis, yeah.
Yeah. As for the dose, my clinical practice, I don't think there's an exact answer. You've got to look at the patient. You've probably given them a lot of atropine. Look at the pupils. Are they pinpoint or dilated? Because if they pinpoint, your muscarinic effects are being stimulated. If they're dilated, you've knocked your muscarinic effects a lot. Usually you can bang in another 2 to 4 milligrams quite happily. Certainly you're not going to bang in 56 milligrams immediately, but if you can push in, something between 2 and 8 milligrams to settle the patient again, and then continue on your infusion, and then maybe turn up your infusion. So give them another 2 to 4 milligrams stat and turn up your infusion a bit and watch what they're doing. If they have a full-on secretory thing, you don't have to hesitate to give them a lot of atropine. 2, 4, 6 milligrams stat, you can easily give them. You certainly don't need to give them 56 milligram stat. So you can give them a good dose and watch what you do, and then increase your infusion rate. And you're literally going to play it by ear. It's a clinical thing. If they need more, you might have to give them another bolus. Keep the infusion going, turn up the infusion, and watch what it's doing. My experience is, a good another 4 to 8 milligrams settles them, and then increase your infusion a bit. I hope that helps. I think there was someone else who had the hand up. Tammy, do you see anyone?
Yes, I do. Thank you very much, Dr. Saffy, for this great presentation. I'm Christopher Columbus. I have 2 questions, basically. Considering the fact that patients that come down with acetylcholinesterase poisoning or toxicity, sometimes or most times present with cholinergic toxidrome, the effect is both on muscarinic and nicotinic receptor. Is it possible for us to have a non-selective anticholinergic drug instead of atropine? Atropine acts only on muscarinic receptor, like you've rightly said. Is it possible to have a non-selective anticholinergic that acts both on muscarinic and nicotinic receptor? Then my second question is, considering the mode of transmission of this poison, should we be wearing PPEs before we attend to patients, or using our gloves alone, we are safe and good to go? Thank you.
Okay, thanks for the questions. There is no non-specific drug that sorts out the muscarinic and the nicotinic receptors. That's why we can't use it. That is why people are desperately looking for options to treat this, because there's a huge problem worldwide, with each country being slightly different to the other country. So yeah, if we could develop that, I'm sure we would love to have it, but we don't have it. That's why I've given you the range of the things that we have at our disposal, and then the other options that people are looking at. The other question, as I showed on my slide, it depends what happened to the patient, how much protection you need. I think most of us have been working with organophosphates for years and years and years. The majority of the types of organophosphate poisoning we see is ingestion throughout Africa, and that is not a risk to you. I promise you, I have never had organophosphate poisoning, but I've been with many patients who've had organophosphate poisoning, because it's ingested, it's in the gut. You use your gloves. If you have a mask, it's fine. You are not going to be poisoned by that patient. I once had a fight with, Barra ICU. They were so rude. They told us we must decontaminate the patient because they are going to be poisoned because we don't look after the patients. We are there in the front line. We have not been poisoned by these patients. Why are they accusing us of not looking after them when they don't even think about us? However, if the patient is covered with this all over their skin, which would happen in an attack, then you have to be thinking of protecting yourself. We have to decontaminate those patients like I showed. They need to be stripped down, they need to be washed off, and the people going near them must be fully covered, because you cannot touch their skin, and because there's the risk of you being poisoned, and especially if it's something, well, it's like any of these, but this VX and the Novichok are incredibly poisonous. So if we have to deal with patients who have been sprayed with organophosphate, we must protect ourselves. And the first protection is wash them down, and then somebody has to remove the clothes. If the patient can't remove clothes, you've got to remove the clothes, which means you must be fully protected. So the history is the answer. An oral ingestion is not going to poison you, but a contamination from a spray, you are at risk, and you have to protect everybody in your ED or your area before you go in to get those patients, remove their clothing, wash them off. I hope that answers everything.
Yes, thank you very much.
Tammy, you want to say something?
Yeah, so obviously we're worried about OPPs in attacks. So fortunately, I want to touch wood, we haven't been subject to such horrific events like they have overseas. But the other patients that we do need to be wary of, obviously, is in agriculture in South Africa. So if you have somebody that's come in with these symptoms agriculturally, you really do need to be wearing PPE, not the patients that have ingested it orally.
Any other questions? No. All right, everyone. Well, thank you very much for your attendance. I hope you enjoyed this. Tammy, thank you very much. And we'll say goodbye.
Thank you so much. We really appreciate it.
Okay. Bye.
Thanks, Dr. Saffy.